All right, so this presentation is about study biases, and we're going to focus on just a few. There are a lot. There are a lot of biases. I am currently the dean at the University of South Carolina Aiken Greg Graniteville Library. I was previously at ACOM in Dothan, Alabama, and before that, I was at UAB. So I have a pretty decent health sciences background, and we have a pretty active health sciences program here too. So I didn't get completely out of the group, but I am enjoying being around historians and stuff and artists a little bit more than I thought I would. But anyway, so we're going to talk about study biases. First, what is a bias? So a bias is a systematic error that is consistent from the true value and usually, or it does go in a specific direction. So it's an error that is consistent in specific decoration, and it affects the accuracy of the findings. And it can happen at any stage of the study, right? So that's why you have to be so careful throughout the entire study, because bias can creep in at any point. Now, if we're going to talk about bias, we have to make sure that we know what random error is. So random error, people are messy, right? So random error is just that unpredictable variation, right? That happens because of chance. It's kind of, you hear the example all the time of flipping a coin. If you've got two sides of a coin, you should get heads 50% of the time, tails 50% of the time. But how often does that happen? So there's chance. And that's why we have p-value and confidence intervals and all of those things. Those things deal with chance. Because if you have enough measurements, those random errors tend to just kind of cancel each other out, right? The average of all the measurements should be close to the true value. So that's why you say you've got a p-value of 0.05, if you're 5% sure that the true value is within that range. And so that's why we have p-value and confidence interval to deal with random error. That doesn't deal with bias. So how does bias happen? Bias can come from a lot of different places and occurs sometimes unconsciously. It's just by accident. You know, you're doing everything right and it's just an accident. The design can be bad. The execution can be bad and have some bias pop in. There's poor planning of people that aren't adequately trained for whatever kind of study you're doing. You could have faulty equipment. We'll talk about that one a little bit. And then of course sometimes we have bias creeping in on purpose. Okay. We all know about that. And then just some other reasons. So let's look at these examples. So bias doesn't average out because it's systematic. So if you use a faulty blood pressure cuff that always reads 10 points too high, all of those readings are wrong in the same direction. So that skews your results permanently. Random error is what they like to call statistical noise. So people give different answers. People forget. People have good days, bad days, all these sorts of things. And these errors are unpredictable and they don't follow a pattern. So that's why you want to have a large enough sample to make sure that you can balance those random things out. So we have main categories for biases. The first one we have is selection bias. So selection bias, that's the systematic difference in who gets included in a study. And this speaks to generalizability. If you don't have a good selection, if you don't do that right, you can't generalize the results of your study. And that's what you want to do. You want to be able to generalize the results to the larger population. We also have measurement and information bias. Those words are used interchangeably, so I just put them with a slash there. I tend to call them information bias, but you'll also, I got the public health background, public health people say information bias, but there are measurement biases. I mean, either way is right. Then there's confounding bias. That's a third variable that is related to both the exposure and the outcome that distorts the relationship between the exposure and the outcome. And we will look at that closely. We also have a smaller bucket here called reporting bias. And it's often treated as like the outcome or how results are disseminated, but it's not they don't consider it a core study design issue. Okay, so what is selection bias? So this happens when people are included in a study that are different in key ways from those who aren't included. So if you can't survey or test the entire population, right? So what you want to do is get a sample of that population that mirrors all the characteristics of that larger population. And you want that little sample to be as much like the whole population as you can get it. If you don't, it's going to distort the relationship between exposure and effect. You see these a lot in case control studies and retrospective studies, where the selection of the participants happens after the outcome, right? So this makes it difficult to apply those findings to the broader population. So you want those study groups to be the same except for the thing being studied, same as you can get them. So let's look at some different kinds of selection bias. So there's a thing called a convenient sample bias, and that's where you get your recruits for your study somewhere that's easy to you, right? So for somebody on a college campus, it'd be the students on that campus. That could be a convenience sample. A convenient sample that we'll also see is in Bergson's bias down there are hospitalized patients. But the convenient sample, college students, you can only generalize that to other college students, right? You can't generalize that to the general community. So if I was doing something in Aiken and I wanted to study something community-wide, and I just use the kids on this campus, I can't generalize that to the larger Aiken community, right? The same thing with the Bergson's bias with hospital patients. Hospital patients in a community are very different from non-hospitalized community. They're getting ideally better care because they're in the hospital, but they're also sicker. So they're different. You can't generalize a study made up of hospitalized patients to that non-hospitalized community, right? Same thing with healthy user bias. Participants are healthier than the general population. So if I was in this community and I want to see, how healthy this community is, and I get all my surveys completed at the gym, well, that's going to make everybody look decently healthy, right? Because I'm just looking at people who come to the gym. I'm not going to other places to recruit from the entire community of Aiken City or county. And volunteers, people that volunteer for things. I've volunteered for studies before because I think it's cool to volunteer for studies. That makes you different. If you like to volunteer for studies, you're different from those that don't, right? Same thing. If we are presented with a study on, let's stick with being healthy, on folks that eat organic food, and so we're going out there asking, we want to see who's healthy, and we're interested in how organic choices do that. Then we're going to attract people who eat organic or who are already healthy and are considering eating organic food. We might not get those that can't afford the organic food, or those that just don't care. They're just going to McDonald's. So volunteer. Why are they volunteering? Volunteers just in and of itself is kind of a different kind of character that you can't generalize to the general population. All right, so we have sample bias. And this is sometimes called sampling bias. This happens when the sample itself is not representative of the population you want to study. So that's, if you have a community and you only get a sample from a certain part of that community, that's not representative of the whole community. Another example is attrition bias. That's the loss of participants in a study is not random, but related to characteristics that could also influence the study's outcome. One example is for, let's just say, a drug trial. You have folks in there that experience horrible side effects and they drop out before they give a chance for those side effects to ease off some. So the drug may still have helped them if they were able to stand the side effects. So you lose that attrition. So they're different. So now you've got a population remaining in your study that aren't susceptible to the side effects. So you don't know necessarily if the people with the side effects, how the drug would have affected them. Now, this is an interesting one, Neiman's bias. It's also called prevalence incidence bias or survival bias. So this is when there's a gap between the exposure and the selections of the participants in the study. So if you have an exposure and then you've got a period of time, then basically you've got the folks that didn't die or recovered quickly from a condition. So the studies, how things started at the front end may be missed, right? All right. Another example of selection bias is non-response bias. And I put this one in here because librarians and health professionals, we love our surveys, right? This happens a lot with surveys where people just choose not to participate or they just give up, right? And some reasons they do this is because the survey is designed poorly. The survey is sent to the wrong target audience. There's an inability to contact respondents, responding to respondent characteristics and behaviors. So if you're asking sensitive questions, the person may not want to disclose that they don't give to charity or they may use drugs or something like that. And then the timing or data collection can be problematic. You don't want to send it at Christmas, right? You're not going to get any sort of response during a holiday period. So how do you control for this? All right. So people are messy and it's very hard to control for selection bias, but we have some strategies. One, of course, is random sampling. We all know that's a good thing. We want the samples to be random. We want ideally everything to be blinded. We don't want either arm or group to know what group they're in, whether they're experimental or the control. We don't want the researchers to know. Sometimes we don't even want really the person to know exactly what we're studying. You can also stratify the sample. So this helps with making sure that you have you record things like age, gender, that sort of stuff. So you have the same amount of each of those kinds of groups in each arm of the study. Matching is another good one. If you can do it, matching. So if you're studying something health related and there are smokers in your sample, then when you divide those samples into the two groups, you want the two groups to try and have the same number of smokers in each group. And then there's statistical ways for doing it, but that's another thing. That's a whole nother lecture. Let's see. Okay, so for selection bias, we're asked for our opinion. So every time, yeah. So yeah, and you don't want to do it, do you? It's just like every time. I'm not answering that. Everything's fine. Now, the other main group of biases are our measurement information biases. And so these happen when the data is collected, it's either not collected right, it's not complete, or it's just not recorded right, inconsistently, or it's entered, it can be entered wrong as well. If you're doing manual data entry, that's a problem sometimes. Participants can be misclassified or measured incorrectly. This can happen with faulty survey questions, memory, you got recall bias, which is on the list here, and then our inconsistent data entry. And all of that can lead to the wrong conclusion because the exposure or outcome is measured incorrectly. So let's take a look at a couple of these. Okay, so recall, everybody knows, I don't remember what I did yesterday, right? So people were calling past events. A lot of times that is a little fuzzy. They say eyewitness testimony is the least reliable, right? So this is common in retrospective studies where you're asked to remember when you got exposed or when did you get get your symptoms first time, that sort of thing. And that can get even worse if somebody's trying to recall it for you, or if a parent's trying to recall it for a child. So you can get really kind of iffy stuff with recall bias. Then there's observer bias. So the person collecting the data may record or interpret responses differently based on their expectations or assumptions, right? Especially if you're an observer and you're talking to somebody that has the outcome of interest, you may probe a little harder, right? You may probe a little harder, or that's interviewed, but you may also misrepresent or misunderstand people's reactions and what they're doing. Performance bias is a very interesting one, and it comes from systematic differences in the care of the provider or the exposure to factors other than the intervention. And this one's weird. It's a form of measurement bias because it's not about who's in the study, but how they're handled once they're in the study. So that's a very interesting one to me. I did pop a few of my favorites in here. Right. You've probably heard of the Hawthorne effect. That's a popular one that folks talk about. That's you change your behavior because you're being watched, or you change your behavior because you're part of a study. Humans humans tend to want to do the right thing. So if they know that they're in a study, they're gonna act differently. I'm supposed to exercise twice a day for this study, so I'm gonna do it, and then they don't do it ever again, or they change their behavior and don't maybe act as angrily as maybe they would if they weren't being watched. Then we have the John Henry effect. This one is the participants in people are competitive. So people in the control group, they may exert a little extra effort or engage a little bit more because they feel they're being compared unfairly to the intervention group, right? So they're like, well, I'm gonna up my game here. Well, that changes things. We don't want that in a study. Surveillance bias is another one. It's also known as detection bias, and this often occurs in observational studies when a certain group is more likely to be monitored or tested for a disease compared to others. And so this is if you have a sample and you're looking at, we'll just say bone cancer, and you know that this group has bone cancer, you may have a tendency, whether you mean it or not, or you're intentionally doing it or not, to do a little bit more with that group or watch that group a little bit closer. Then we kind of referenced interviewer bias before, but that refers to a systematic difference between how information is solicited, recorded, or interpreted. And so if we talk about interview bias and the interviewer knows that the person has the outcome or experience exposure. They may ask more probing questions. They may just ask them differently. How does that work? I mean, how do you know? Give me more detail when you're not supposed to do that because you're supposed to do the exact same thing each time. Lead time bias is another big one. That occurs in disease screenings where you have early detection. So then you have an inflated survival statistic, right? Because most people, they're diagnosed when they have symptoms. So if you have somebody who has a screening and the disease is found earlier, but it's not going to change the outcome, it makes it look like they lived longer when they really didn't, because you don't know when the person who came in with the symptoms would the disease would have been caught with a screening. That one, students have a hard time with that one. And then there's the social desirability bias, which we kind of mentioned with the surveys, that you want to answer in a way that makes you look good. It's not true. Well, do you give to the animal rescue fund? Of course I do. Every week I give every week, and nobody gives every week, right? Very few people give every week. So how do we control for this? You want to make sure that your system design and calibration is done regularly, accurately, and everything is in perfect working order, right? You want to ensure that the instruments are working as they should. You want to take the measurements more than once. I know probably everybody on here has gone to the doctor, gotten their blood pressure checked, it's been high, and then they waited like 5-10 minutes, took it again, and it was back to normal. So repeating measurements to make sure you're getting the accurate measurement is important. And then just testing the calibration of instruments, having consistent standards, consistent protocols that everybody knows to follow. You want to make sure that the data collectors have been trained, they know how to use the instrument properly. There's all kinds of cool observer training you can do so that you don't have that bias when you're observing people's behavior, or at least less likely. And then blinding, you don't know who's been exposed or who has the disease or who's in the control group. You don't know, so you don't have any subconscious or just desire to like probe the person that has been exposed a little bit harder. Then there's pilot testing, consult the experts. Always a great idea to talk to a statistician as you're designing your project. I don't know how many times I've had physicians and even PhDs come and say, well, I got my data and I want to do this with it. And the statistician had to say, well, you can't, because you don't have the right variables and the right data to do that test. You'll have to do this test. Well, I don't want to do that test. Well, I am so sorry. You have to do that test. Now, this is a good one. If you haven't heard of confounding before, it's a whopper. It's what we call it, high yield, right? So a confounder is a third variable that messes with the relationship between the exposure and the outcome. Now, it's related to both the exposure and the outcome, and it can trick you into seeing a connection that may or may not be there, right? So a confounder is a third variable that is related to the exposure, it's related to the outcome, and it's not on the causal pathway. So it can make an association look stronger, weaker, or it can be fake. So this is a cool graphic. This one talks about antioxidants. So the main question is, what are the effects of antioxidants intake on cardiovascular disease? But the list here are confounders, because age also affects cardiovascular disease. Aspirin use affects cardiovascular disease, but aspirin use does not affect your antioxidant intake, and antioxidant intake does not make you take aspirin, right? So those two, the antioxidants and the confounding list here, they're not related, but they all affect cardiovascular disease. So a more simple example, so You may have seen this one. We say, well, we think, people that come in and they have lung cancer, they drink a lot of coffee. So I'm going to see if coffee is causing lung cancer. But the people that drink, that's what they say, people that drink a lot of coffee also tend to smoke, right? So it's not the coffee that's causing the lung cancer, it's the smoking that's causing the lung cancer. But because if they don't know, if they're not looking for smokers in their group of coffee drinkers, they could conclude that coffee causes lung cancer, right? So it's a confounder. And that's that third variable. Now, it's important that that's different than effect modification. Okay, so effect modification occurs when the effect of an exposure changes in response to a third variable. It's not a bias, it's real and it's meaningful, and it tells us the relationship is different across groups. And so the example I have here is like if a heart medication lowers heart attacks in men, but doesn't show any benefit for women. That means that drug is modified by something that has to do with being a male. So that's a real difference. It's not an error. And so my little quotes here, confounding hides or fakes an effect. Effect modification reveals a difference that matters. And confounding is something you control for, and effect modification is something you report. So I know we're running kind of getting low on time. I did make a chart. So if you go back and listen to it, you can come back to the chart. But to control for confounding, we have these strategies. You can look them up: randomization, matching, stratification, restriction, and then our multivariate analysis statistics. But I didn't want to end this one without including citation publication bias, because we're librarians, right? So citation bias refers to that where researchers and trial sponsors, they don't want to publish unfavorable stuff, right? They want to publish the positive stuff. The publishers want to publish the positive stuff. So what we see in the literature, the results are much more likely to be submitted and published for a positive than a negative, right? And then I put my favorite one up here. And if you look at the data sources, it's got all the good stuff. And then it says clinical trial registries, trial results databases, regulatory authority websites, blah, 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 blah. And then when they did this systematic review, it said that the drug reboxetine was not helpful, and in some cases it was harmful and affected by publication bias. So I wanted everybody to see that one as a librarian, because that's something that's kind of near and dear to us. And then this is a slide just of what to watch for. Say if they weren't randomly selected participants, you want to watch for selection bias. If groups weren't treated the same, performance bias. Is the data self-reported or retrospective? That could be recall or another kind of information bias. Did people drop out? There's attrition bias, right? Are the results dramatically positive? That's that small, narrow sample size. Always ask about generalizability and publication bias. Was there a third factor influencing the results? And was the study group generalizable to the appropriate population? Always consider confounding. And if the important outcomes were not reported or vaguely defined, you might consider reporting bias. So we got a little summary. So bias is a systematic error, not randomized noise. It can happen at any stage of the research project. But if studies have bias, it doesn't trash the whole study, right? But you need to know that it's there, and the author should in their limitations put that in there, that this is kind of like, we had a small sample size, this may not be generalizable, or this happened to our data, but we still found this. They should be honest in that. And then for the last little bit, right at 1:30, I just picked up some resources. I'll leave that on the screen for a second. I think probably most of them you all have seen. And then the final slide is just my name and email and thank you. So if anybody wants to hang out for a question or two, we can do that.